Okay, welcome. We are going to try a little different technique to learn chronic renal failure. It is called Explain Everything. And you'll notice it's a PowerPoint, but it has voice with it, and I can also doodle or highlight what it is that I think is important. And so I hope you like it. This is to be completed before class, and we'll pick up on actual care then of the patient with chronic renal failure in class. Okay, so we're going to do chronic renal failure, and as you can see, this is in your med-surg text. It is on page 1107 to 1131, so go ahead, go find your book. Hopefully you're not just now taking the shrink wrap covering off of it, and turn to page 1107 and let's get started. The objectives would be that you could understand what's going on with the kidneys when someone's going through the stages of chronic renal failure, that you'd be able to understand what a newly diagnosed patient has to deal with, and you know that many issues, including ethical issues, that the patient and family have to face when they are going through chronic renal failure. Okay, so let's talk about chronic renal failure. Chronic renal failure or chronic kidney disease is where the kidneys progressively lose their ability to actually filter. That's their primary responsibility. So over time, they lose their ability to filter. There is, in your book, on page 1106, a table that shows you that there are actually 5 stages of chronic kidney disease. And someone is considered to have chronic kidney disease if their GFR is less than 60. GFR is glomerular filtration rate, or essentially the kidney's abilities to filter out waste products. And so that's chronic kidney disease is a GFR of less than 60. Once we get into the 5th stage, which is considered end-stage renal disease, then what do we have? We have a GFR that is less than 15. A GFR that is less than 15. And so it is a progressive disease. The issue is this. The issue is that there is a huge percent of the population in the United States today that has chronic kidney disease, but they do not realize it because essentially many people stay asymptomatic, meaning they have no symptoms of chronic kidney disease until they've had a significant loss of nephrons. Okay, so as I said, this is the 5 stages of chronic kidney disease. And if you look on page 1108, you can tell that these are measured by the GFR. Okay, so for instance, you're in stage 3 if your GFR is between 30 to 59. So this would be 30 to 59. Okay, what do I expect you to know? I expect you to know the information that I gave you on the previous slide. Chronic kidney disease is less than 60. End stage is less than 15. Okay, so maybe you are thinking, what in the world is a GFR? If you go back to page 1048, it outlines and tells you what the GFR is. But a normal GFR is 125. And once again, it's just the kidney's ability to actually clear what it's supposed to be able to clear. So normal GFR is 125. So then how do they calculate a GFR? You have to have a blood test, but there's not a specific blood test for GFR. What we do is we take the patient's results of their creatinine, their BUN, their albumin, and a male or female race, and it calculates a GFR. So again, a GFR is not like a specific blood test, but we actually take the results of the creatinine, the BUN, and the albumin, take in consideration the patient's male or female, age, and some take into account race. Okay, on page 1108, it goes over, why there's been such an explosion of chronic kidney disease in the United States. Still, number one, number two cause is diabetes and hypertension, and so diabetes is number one. 50% of the reason people have chronic kidney disease, and then we have hypertension coming in at number two, and it's 25%. And so essentially, later on when we learn about diabetes and we learn about hypertension, you'll understand why these are the number one and number two causes for chronic kidney disease. And then you can read through some of the other causes of chronic kidney disease. Another issue with the United States today is the increase in the obesity rate, and typically people who suffer from obesity also suffer from diabetes and hypertension. So it's just been kind of a ripple effect. We've had an increase in obesity in the United States, which has increased diabetes and hypertension, which therefore has increased chronic kidney disease. Okay, as I said, when people first start to develop chronic kidney disease, a lot of them don't actually have any signs and symptoms. Their urinary output typically stays the same. Some of them actually might have polyuria because they have diabetes, remembering that that's the number one risk factor. But then eventually, as the chronic kidney disease progresses, they'll go from the polyuria to the oliguria. Okay, the kidneys will lose their ability to concentrate, and the BUN and creatinine will start to go up, and these will then start to be reflected in a declining GFR, which we've already talked about. We're going to talk a little bit later about why they develop anemia, but many of the signs and symptoms that patients initially have with chronic renal failure is because they start to put on water. And so that's why they have headaches. That's why patients develop edema. That's why their blood pressure is elevated and they develop hypertension. They have weakness and fatigue. Obviously, their potassium goes up. And remember, an elevated potassium is called hyperkalemia, which is greater than 5.0. The potassium starts to go up because, the kidneys have lost the ability to do their job and clear potassium. I want you to pay attention to the cultural and ethical health disparities. There's a chart on the top of page 1108, and it reminds us that minorities have a much higher incidence of chronic kidney disease, and that the population most greatly affected are African Americans. Okay, signs and symptoms as patients progress through the stages of chronic kidney disease and they end up in end-stage renal disease become more significant. If you're looking at your book on page 1109, there is a person and it's kind of outlining all the different systems that are affected. What I want you to get from this is the fact that every single body system is affected when someone is in end-stage renal disease. They're some of the sickest patients that you guys are going to take care of. So no system is not affected. What's challenging about this picture that you guys are looking at and the picture in your book is there's a lot of terms here that you guys might not necessarily understand. And so you're going to have to stop and take the time to look them up. We're going to get into them a little bit more, but even just kind of looking over this, some of the signs and symptoms that you guys might not understand, for instance, would be CVP, which stands for central venous pressure. That's a measurement within the heart that tells us about your fluid status. And so, for instance, if someone has an elevated CVP, we know that they are fluid overloaded. Pericarditis, for instance, pericarditis, if you remember, itis is inflammation, and that's just an inflammation of the lining of the sacs of the heart. So you're going to have to take time to look up the various terms that you do not understand and the various terms in your book that you do not understand. And we'll go into some of these a little bit more on the next slides. Okay, so cardiac system is obviously affected in chronic kidney disease. This is on page 1110. Actually, the cardiac issues that patient experience with chronic kidney disease is typically what leads to the end of their life. So what we have here is kind of a round robin where, like we said, many of these people have hypertension, and then as the kidneys decline and we have an issue with sodium retention and water retention, then you can see that that would lead to worsening hypertension. So if you happen to have a patient who did not have hypertension prior to having chronic kidney disease, they will develop hypertension as they hold on to sodium and water. So as they hold on to sodium and water, they develop hypertension, they develop edema, and they have a tendency to have heart failure. And we'll talk a little bit more about heart failure later in the semester, but heart failure is essentially damaged heart muscle that cannot pump effectively. Those are just a few of the cardiac issues. If you flip back on page 1109, it talks about the issues with electrolytes, and the biggest one is potassium. Once again, kidneys are damaged, unable to clear the potassium as they're supposed to, and so, excuse me, it builds up. The patient develops hyperkalemia, which is defined as a potassium greater than 5. And so along with that, it causes cardiac problems, especially dysrhythmias. Dysrhythmias are abnormal EKG tracings. And so someone who has hyperkalemia will have dysrhythmias, which are abnormal heart tracings, and it will also have an increased risk for sudden cardiac arrest because of the increase in potassium. Okay, on page 1109 it talks about why patients with chronic kidney disease become anemic. And the reason is because as the kidneys decline, they lose their ability to produce the hormone called erythropoietin. Now, erythropoietin is needed because it is released from the kidneys and it tells the bone marrow, hey, produce more red blood cells. And so when it's not released, the bone marrow is not getting that signal, and then so you have a decrease in your red blood cells. And so that is why people who have chronic kidney disease become anemic. You can look at acid-base balance. It's also on 1109, and it talks about these patients become or develop metabolic acidosis. At this point, I understand you don't know what metabolic acidosis is, but it is essentially the result of kidneys' inability to excrete their acid load. Okay, and then we have issues with the musculoskeletal system that lead to complications. So what happens with the musculoskeletal system? It's actually kind of what I would call a trickle-down effect. Okay, the kidneys deteriorate as we talked about, and so there's less vitamin D that is converted to its active form. And so remember that vitamin D is necessary for the absorption of calcium in the gut. Well, that doesn't happen because we have less of it. So then the parathyroid gets involved and thinks, okay, my patient's hypocalcemic, I need some calcium. So it releases the parathyroid hormone and it tells the bones, hey, release some calcium because we have low calcium levels. Well, you can understand how this would have a trickle-down effect. as it gets this message to release calcium, then the bones actually become demineralized, or they become weak because they're releasing this calcium. But also along with that, it releases phosphorus. And so, like a person with chronic kidney disease needs something else to do with, they develop hyperphosphatemia in addition to many other electrolyte and mineral abnormalities that they develop. So, like I mentioned before, every single system is involved. The kidneys decline, you develop more and more signs and symptoms, but you develop uremia, and uremia is something that you guys need to understand is just an elevated BUN. Okay, so you develop uremia. And then we've talked about all the different electrolyte and mineral disorders. And so you guys, I strongly encourage you guys to take the time and read in your book from page 1108 to 1111, and it talks about the additional signs and symptoms that people who have chronic kidney disease develop. Again, just additional signs and symptoms that patients going through chronic kidney disease develop. Okay, so when we are going to start to evaluate whether someone has chronic kidney disease, obviously you want to get a history and physical, and we already talked about the type of assessment that we would do for someone for GU systems. We talked about that yesterday. So history-wise, though, it's obvious that you guys want to make sure that you're asking them. Remember, what was the number one cause? Diabetes. What was number two? Hypertension. What were some of the other ones? If you don't remember, go back and look. I would be able to identify these various causes of chronic kidney disease. So then, let's talk about a CBC. What is it that you think you would see that would be abnormal on a CBC? Remember that we talked about the fact that they would have a low red blood cell count. Why was that? Can you remember? Because of the lack of the production of the hormone erythropoietin, which is needed to stimulate or tell the bone marrow, hey, produce red blood cells. Often you also see a low hemoglobin. Okay. These guys have a tendency to have bleeding issues, so they'll do clotting studies, coagulation tests. If they are diabetic, we like to see what their hemoglobin A1C is telling us. Remember, a hemoglobin A1C gives us a snapshot of the daily blood sugar level over the last 3 months. Urinalysis is important. We're going to run a UA, and we're going to look for protein. In a UA, you can see protein. You can see white blood cells, red blood cells. Those are some of the things that you might see in patients who are developing chronic kidney disease. You can actually dip their urine and check for protein. A lot of times in like World Kidney Day, they'll have this set up in various areas, and patients can come in and have their urine dipped to make sure that there's no protein, and if there is, then they should be followed up on. And then we talked about creatinine clearance and why that would be necessary for someone who has potential chronic kidney disease. Okay, we talked about these things for our fluid and electrolyte lecture. What you might see here, though, remember for electrolytes, is that you're going to see what? An increased potassium, a low calcium, and an increased phosphorus, right? My handwriting's getting sloppy. You're going to check the renal function labs, which are BUN and creatinine, and you're going to expect those to be elevated. A lot of times they will do a renal ultrasound to make sure there's no kind of obstruction, see if the kidneys in any way have changed shape, size, and would do a CAT scan of the kidneys for the same thing. Just remember on the CAT scan This could be dangerous. We're talking about you're being worked up for chronic kidney disease. Do we really want to give this person some type of dye? So they have to be very cautious in someone who is going to have a CAT scan and possibly giving them some type of dye. And then a renal biopsy if necessary. But your mind should pop to, hey, should they really have a renal biopsy? We need to look to make sure that they haven't developed the bleeding tendencies. And so care, as you can tell, of someone with chronic kidney disease is very complicated. So what we're going to do is finish up this lecture that you guys have listened to, and then when you come to class, we're going to start in your book on page 1112. I'm going to start to talk about collaborative care. We've laid the base. You know that these guys are really, really sick individuals, so how are we going to care for them? I will tell you this, that remember you're going to have pop quizzes, right? During the semester. Pop meaning that you would essentially not know about them, right? Well, I'm telling you, the first one, number 1, is going to be on this presentation. And so if you listen to this presentation, you're going to be able to do well on this pop quiz, which I'll just do 5 questions. Okay? If you have any questions, just let me know. Thanks.